Welcome to the Society of Thoracic Surgeons INTERMACS and PDMACS user group webinar for this afternoon. Appreciate everyone logging in and taking some time out. This is our first of a series of user group webinars, and we're going to target the PDMACS database today. We have Dr. Awais Ashfaq. He's the assistant professor of congenital cardiac surgery at Johns Hopkins All Children's Hospital, and he's going to be joining us today and giving a presentation on the device types that go into PDMACS. So before Dr. Ashfaq gets started, I'm going to go and just review some things really quickly so we can use the majority of our time for his presentation. After he talks, we may have some time for Q&A, and if not, you can just email myself or Patricia Potter with any questions. So welcome to the INTERMACS Data Warehouse team who's joining the call today. Just wanted to, again, I've already introduced Dr. Ashfaq for being the presenter today, and again, thank you very much. As far as STS updates go, this is regarding INTERMACS. We do have a dashboard and some updated adverse events that will be going live in the next couple of weeks, and those will be presented at AQO. Our AQO 2021 meeting, the INTERMACS and PDMACS Day, is Tuesday, October 12th. And if you have not registered, please go ahead and do so. It's complimentary registration this year, and we look forward to we're going to have a really great program. With that being said, I want to go ahead and introduce Dr. Awais Ashfaq again from Johns Hopkins All Children's Hospital, and thank you for presenting and your patience today, Dr. Ashfaq. I will stop sharing so you may share your screen. Okay.
All right. Thank you very much.
Thank you.
I'm glad to be here. Can you see my screen okay?
Yes.
Swap that again. All right, there you go. As was mentioned earlier, I'm going to be talking about just the devices that go on in PDMACS, and then maybe a couple of other things that probably have not been seen by a lot of centers, but some centers have started using those devices in PEDS patients. So briefly, I'll talk about some indications. Let me hide this. Indications, and then talk about temporary VADs that are used in pediatric patients, durable VADs, and then what constitutes a BiVAD and some additional support. As part of this talk, I will not be discussing ECMO because I think that's pretty standard at every place that does ECMO, and so I don't think we need to spend a whole lot of time on that. As far as the indications go for pediatric patients, most commonly patients who present with idiopathic dysfunction have some form of cardiomyopathy or myocarditis. And then some patients have malignant arrhythmias, and most common of these are intractable ventricular tachycardias, for which these kids end up getting shocked, or sometimes they even have an ICD in place, but because of persistent defibrillations, they present to the hospital and may need mechanical support. Some instances, they can be used in post-cardiotomy, and post-cardiotomy here implies all patients who either cannot wean from bypass for whatever reason, or end up having a post-operative cardiac arrest in the first few days after an operation. And then some challenging patients, which nowadays we've been doing more and more, and those include single ventricles and especially failing Fontans, who have started to get some durable VADs and have been really good for those patients. And a small fraction of these patients who have been transplanted before but because of serial rejections have developed vasculopathies. And as a result, they develop ventricular dysfunction and are either relisted or have to be bridged to a decision. And most often, these patients, if they have a transplant-associated vasculopathy, will end up getting will end up needing biventricular support. Temporary support, for all practical purposes, again, is used for patients who either they fail to come off bypass, or it's used as a bridge between different forms of mechanical support, where you may consider them bridging from an ECMO to a durable VAD with the hope that it may recover on a temporary VAD. And so these kids may end up needing temporary VAD support. And in a small subgroup of patients may just need isolated right ventricular support. And most commonly, this is done using a temporary mechanical support strategy. And again, as I mentioned earlier, some patients who have low cardiac output state with the potential for recovery may just need temporary support as a bridge to recovery or as a bridge to decision. And these are patients who often presents with the myocarditis, cardiomyopathy, and or transplant related, just to give them time for their rejection treatment to get working. One of the most common temporary MCS devices that we use is basically a version of a cardiopulmonary bypass pump. And it's essentially called CentriMag, but what the CentriMag is basically this pump right here, which you see. And it's used in the form of a bypass circuitry where you have venous line, which is depicted by blue here, and then a red line, which is depicted by red tape here. And essentially the blue line will bring all the blood back from the patient, and then this pump will pump it back using this other line that goes back into the body. And again, there are different cannulation strategies, but most often if someone needs, if let's say we talk about ECMO, this will be a component of an ECMO circuit. But if someone needs a temporary VAD support, even either central or peripheral, then after they get cannulated, either in the femoral vessels or centrally most commonly in the aorta and in the right atrium, the lines will come back and they will be hooked to this pump, which will act as basically their ventricle. The good thing about CentriMag is it can go up to as high as 10 liters of flow, and there's no size restriction. And a version of this is a PDMag, which is essentially a similar pump but smaller volumes. Patients can be supported up to weeks on this, and this can be employed because it's so. The pump, you can add on as many pumps and you can attach them to different cannulas. You can use it as a univentricular support, a biventricular support, and most commonly patients with single ventricles who are in interstage end up needing something, they would most commonly get this as a temporary fashion. And this pump uses a continuous pump flow. And so basically it's an axial flow, and it keeps pumping throughout the cardiac cycle. Some centers use Rotaflow, which is a version of CentriMag, and essentially it's a centrifugal pump as well, but it uses this different strategy. Rather than having a motor in it, the blood comes in and it swivels around this circular pump inside, and it goes out to the arterial cannulation site. It's just a different strategy, and people who use Rotaflow, they use it as part of their regular pumps, and so it's just a matter of I think preference of the hospital, whichever pump they stock for their usual routine cases. Again, very similarly, there's no size restriction for this. Patients can be supported on up to weeks. Can be used for both univentricular or biventricular support. And again, it's a continuous pump flow mechanism. This is another version of a temporary support. Is not used in pediatric patients a whole lot, but older patients with congenital problems and adults with congenital problems may end up getting these. Again, not a lot of centers use it. Um, the principle behind this is um, to act as a left ventricular assist system, but it's inserted percutaneously. So as you can see in the picture here, showing this figure, it's cannulated percutaneously and attached to a pump which is outside, and this pump could be any version of a temporary pump that you use, and most often it's a Centromag. Um, it's attached to the cannulation site, and the percutaneous cannulas go in again into the femoral vein and femoral artery, and the main outflow chamber, or the outflow cannula, which is it comes from the vein, goes through the IVC, and usually it's in place in the cath lab, and the interventional cardiologist, they do a transeptal puncture, and through the transeptal puncture, this cannula goes across the atrial septum into the left atrium, and from there it takes out all the fluid, and then it's inserted back into the femoral artery down in the groin here. The good thing about this is percutaneous. Obviously, as you can imagine, the biggest hurdle in smaller patients is access. Because it's a good sized cannula, it just depends on how big the vessels are. This is mostly done for univentricular support, most often left ventricular support. It's again a continuous flow, because essentially, even though the technique is different of where the cannula sits, it's based on this pump which is outside, and since that pump is similar to a Centromag, it's going to be a continuous flow. Usually the duration of support in these patients is just a few days, and a lot of times this cannula, the major trouble with these cannulation strategy is that it moves in place. And so patients with this would end up getting routine serial echocardiograms to see if that tip stays in the left atrium, because sometimes it can migrate out. And as you can imagine, that can interfere with the flow, and hence cause some issues with the patient. Or it goes towards the left ventricle and engage in the mitral valve. This is a newer version of strategy, which is again mostly used in adults, but some pediatric centers are also using it for their older patients and some smaller patients as well. Again, this is a version, the technique is percutaneous as seen in the previous picture, but the way this pump is different is it comes through the arterial side of the systemic circulation, and it's placed under fluoro guidance, again in the cath lab, and it crosses the aortic valve, and one end of this pipe, basically this cannula, has two holes, a hole on the end, on the distal, on the tip, and then the other hole sits above the aortic valve. And the philosophy behind this is the hole that sits near the tip is in the left ventricle, and what it does is it sucks all the blood through this hole into this cannula, and then pulls it back and pushes it out through the hole that's above the aortic valve, hence bypassing this whole system and helping the left ventricle by emptying it out. So it sucks it and then basically throws it out in the aorta, and then goes into the systemic circulation. There are a couple of issues with Impella. One of them is access. The other is an aortic valve issue. You have to be careful, as you can imagine, because the Impella has to go in between the aortic valve leaflets. And because it's done under fluoro guidance, you have to be sure that you're crossing the aortic valve at the appropriate, through the center of the aortic valve. And in some cases that can be damaged. Again, similar to a tandem heart, you have to be careful with where the Impella sits, and it can move as well based on the patient's mobility. And if the patient is extubated or agitated, it can result in a change in Impella position as well. Patients can usually be supported on days. In some instances, or in older patients, we have used a bigger device, which is a 5.0 Impella, which essentially means it can support up to 5 liters or 5.5 liters. In those instances, we have cannulated the axillary artery by a graft, and then tunnel the Impella in their subclavicular region. And in doing so, it helps them get extubated and ambulate while they're being supported with Impella. It's again a continuous flow system and a univentricular support system. Now, in terms of durable support, there are a couple of options for pediatric patients. The most commonly used, or the most, I should say, the most well-studied in pediatric patients is the Berlin heart. And I'll talk a little bit more about this because there are not many clinical trials in congenital heart disease to begin with. But one of the trials that studied studied Berlin, and then it came into use quite a lot after that. So essentially, there are different versions of the pump, as you can see here, and it goes, it spans up to 60 mils of flow that they can support. It's usually employed in patients who are more than 3 kilograms, and the duration of support can be years. It can be, again, a uni or biventricular system. This is a pulsatile flow system, and it mimics the cardiac cycle. And this is the only device, or yeah, I should say, this is the only device, durable device, that has been exclusively labeled for children. And as you can see in the picture here, the cannulas, again, if it's univentricular or biventricular, the cannulation strategy is going to be the same. Either one of the inflow cannula goes into the LV apex, from where the blood goes out of the heart into the Berlin pump, and then there's an outflow cannula that sits in the ascending aorta. And usually there's Berlin cannulas come with their own cannulation grafts that are used for this purpose. And as you can see here, these grafts are then tunneled through the skin and then are connected outside through these connectors to the pump, so that the patients can be extubated and do and participate in physical therapy. They usually come with a driver, which is called an ICUS. It's a console, and it controls the Berlin pump. This is the monitor that people see. It sits on this console, and this is the whole driver that goes with it. And as you can see, even though it's a durable system, it's still burdensome. I mean, yeah, patients they're usually in the hospital, and they can't be discharged. This whole ICUS system houses the compressor and the pressure suction regulators, which is the philosophy behind the Berlin pump and how it works. Usually it's connected to a continuous power source, but if not, then there's a 30-minute battery that it can function without an AC power source. And if everything goes away, then there's a hand pump that comes with it as well. And people who use a Berlin pump, or providers and patients, they get trained to use this hand pump, so that in case there is no power, they can still use that pump to use the Berlin and keep it pumping. This is a heavy apparatus, as you can imagine. It's 220 pounds. Just to give you an idea that it's really not that portable, even though we say, okay, it's a durable system. It's still not ideal. Now, the reason why this came out was this was one of the first trials that looked at Berlin devices, essentially in the form of left ventricular support. But because at that time there were not any other good strategy, they compared ventricular assist devices with traditional ECMO. And in this, they only used a Berlin system, and they included patients who were less than 16 years of age. The primary endpoint here was time to death or weaning from device with an unacceptable neurologic outcome. And as you can see, they used two cohorts, retrospective cohorts from registries at different time intervals, just to see if there would be any difference. And with both of these cohorts, you can see that the survival with ECMO was abysmal. I mean, both groups. And with VADS, it was definitely significantly different. But I will show you in the next few slides that even though it was better, it's still not what it is today. So then they looked at different outcomes in terms of death, heart transplantation, weaning from the left ventricular device weaning from the ventricular device, but still dying or having an unacceptable neurologic outcome within 30 days. Even though they were okay at the time of weaning, they still had issues within 30 days. And then the fourth group was weaning from device because either it was a terminal wean or they had an unacceptable neurologic outcome. And again, here, these are two cohorts, and this will tell you that the different rates of all these patients. And the whole purpose of this graph is even though patients are alive, which is the yellow line in both cohorts, the survival or the complication rate kept on increasing, as you can see, because of the downward trend. And the study showed that, yes, the survival rates were higher with VAD, but most of the patients who survived still had adverse events. And those events were either they died and if they were not transplanted, then they succumbed to something or the other that was irreversible. As a result of that, then a lot of centers who started using these Berlin, there was a time period in between where people stopped using it because of these issues. And then primarily because of action, a lot of there was a revival of protocols of taking care of these patients. And here, if you see, this is a post-approval surveillance study. This was published, I think, last year or the year before, where they looked at the current cohort, which is seen in green, and then the historical cohort that was used in the initial trial. And as you can see, the freedom from first major adverse event, which is, again, unacceptable neurologic outcome, death, is significantly different. And the current cohort was doing much better. And this is both here and in terms of patients who end up needing a pump replacement, again, significantly better. And this was all based on a different or a better anticoagulation strategy, mainly with the use of BiVal. And just with that one drug, a lot of the outcomes were different. This pump was also used in a few patients. This was, again, a continuous flow system, an axial flow, an implantable pump. As you can see, it was placed in the left ventricle with a sewing cuff. There was a motor attached to it and an outflow graft that went and sat on the ascending aorta. And the other end of the pump had a connector and a drive line that was tunneled through the abdominal wall and was connected externally to a power system. This was a good system. This was a lot of it was most of the implantations were done in adults, some were in older kids as well, as durable, and some were sent home. People could be supported years on this, and you could basically fashion it as both either univentricular system or biventricular patients who needed durable BiVAD support. However, recently, I'm not sure how many of you know, but this was recalled, and this was owned by Medtronic, and they just stopped producing it. And a lot of the and the reasoning behind that was their neurological adverse events were going up, and they're worried about pump failures. And essentially, now I don't think people are going to be implanting those, but there may be patients out there who may still have this and who are being supported by these pumps. But most importantly, the thing that has replaced that is a HeartMate 3 device, which is it was already started to use when I was in training. It was a big shift. In my first year, we were doing mainly HVADs, and then the big trial came out, which I'm going to talk about in a little bit, and everyone switched to HeartMate. At least we did. And I basically didn't see an HVAD after that. And I've only seen HeartMate 3 implants. But it's also being used more and more in pediatric patients, and essentially the neuro category or subgroup of patients with Fontanes. The traditional restriction for these pumps have been a BSA of greater than 1.3. However, we've also used these in smaller patients who had a Fontan. And in my fellowship, and some of my mentors have used it to as low as 0.8 or 0.85 to 0.9 BSA. It's a durable pump. Again, it can be used for years of support, can be employed either univentricular or biventricular fashion. And again, a continuous flow system. And just to give you an idea, I think the accessories of the HeartMate 3 is similar to a HVAD. I mean, it has an outflow graft, it has a drive line. Again, it's attached to a controller, pretty similar to everything else. It's just the technique and this internal pipe of the HeartMate 3 is a little bit longer than HVAD, but the pump itself, in circular wise, it's a little bit smaller. The reason why this came into being was this study, which it's called the Momentum 3 trial. Having said that, this was not studied in pediatric patients, but a lot of data comes from there. And the reason for why people have switched to HeartMate 3 is it looked at two categories of pump: an axial flow pump, which was the older generation HeartMate 2, and some HVADs, and then a newer generation HeartMate 3, which is a centrifugal flow pump, which is based on a magnetic principle. And the primary endpoint of this, and this trial was again published in New England Journal, and the primary endpoint here was survival free of disabling stroke or reoperations to replace or remove a malfunctioning pump at 24 months after implantation. So this was a 2-year outcome study. And if you can see in the graph, the centrifugal flow pump did better than axial flow pumps with event-free survival. And as a result, a lot of centers switched to this. There were less neurologic events, there were less thrombosis of the pumps in general, and as a result, there were less need for pump replacement. And it showed that a magnetically levelated pump, which is HeartMate 3, was associated with less need for pump replacement, and it was superior with respect to survival if you look at strokes or reoperations to replace or remove a malfunctioning device. SymCardia is another version of, it's again a implantable, durable system, only used for biventricular support. Initially, it came out with just a 100 cc pump, which was used for adults, but now there is a 50 cc pump for pediatric patients. This can provide years of support in a biventricular fashion, and the pump is based on a pulsatile flow pump mechanism similar to a Berlin pump. And the whole essential strategy here, and I will show you some pictures just to give you an idea, but is to remove these ventricles, right and left ventricle, remove the valve apparatus, and essentially sew these two pumps into the atrium, and then sew the outflow grafts to the respective arteries. And currently, the 50 cc pump, which I'm sure we are more concerned about, is the one that's used in pediatric patients. Is approved only as a bridge to transplant in the U.S. And in order for patients to be eligible for it, they need to have certain measurements based on a CAT scan and 3D measurements to see if they will be able to accommodate this. This is intended to support patients with a BSA of less than or equal to 1.85. And again, as I mentioned, it's just approved as a bridge to transplant. The destination therapy trial is ongoing for adults in the United States. This is just to give you an idea of the total artificial heart. And here, I'll start here and we will go through the order one by one. And I'll try to make this short because I realize this is not the focus of this talk. But the principle is to remove the entire RV and LV at the AV groove. And once you take it out, you remove the valves, both the tricuspid valve and the mitral valve. And so then you're left with looking at the heart from down up. And you can see here, this is the right side, this is the left side, and this is the right atrium and the left atrium. And then you sew a sewing cuff around these two atriums, and you sew the outflow grafts. One outflow graft goes to the aorta and the other one goes to the pulmonary artery. And then the pulmonary artery graft goes to the pump that's going to be acting as a right ventricle. And the other outflow graft goes to another pump, which acts as a left ventricle. And then it also has drive lines that are tunneled out of the abdominal wall. This is the smallest pump that we have so far. It's called the Jarvik. It's essentially for patients who are 3 to 15 kilograms of of size. Again, it's intended for univentricular support, but it's only in clinical trial so far. And the trial name is Pump for Kids, Infants, and Neonates, which is the Pumpkin trial, and it's ongoing. The initial enrollment was just 10 patients, and they're supposed to close it towards the end of this year or early next year. So we'll see what the results show of this. But this is, as you can see, it is as small as a AA battery, and it will be very good for our patients if it comes to fruition. But we still have to see what the data shows. Thank you very much. I think that's all I had.
Thank you. Thank you so much, Dr. Ashfaq. I'll go ahead and share my screen. If you could stop sharing, I'll share mine.
Okay.
So do we have any questions regarding the presentation, or any questions regarding the PDMAX database in general? So you can type them in the Q&A box that we have. So while we're waiting on questions, again, thank you so much, Dr. Ashfaq. Thank you for taking the time today for the presentation. It was very informative and educational, and we really appreciate you doing that for the PDMAX community.
No worries. My pleasure.
So while we're waiting on some questions, I'm just going to go through. I think, do you mind? Oh, it looks like we have a question. So.
Yeah, I think I've been following that as well, to be
Okay.
honest. And no, I mean, I'm looking at the question. They're talking about if the new CARMAT ACE and total artificial heart will be used in pediatric patients. I hope so. I mean, they have to come. I think we are at a very early stage where they're just looking at, even though it's been used in the Europe, but in the US, it's not been used in adults, and the trial is just started. When that finishes and what the data shows, and then it's going to come to pediatrics, it's going to be a few years, I hope. But as far as the company goes, they don't have a pump, as far as I know, for pediatric patients yet. But again, I think it'll be great just to have another option.
So this is Catherine Holyfield, Dr. Ashfaq. I had a question. So with the HVAD not being produced and available or implanted anymore, is there, I know you had mentioned the HeartMate 3. Do you believe that pump, that will be the main durable and dischargeable pump for these patients?
For the time being, yes. I mean, we don't have a lot of other options for bigger patients, and with the HeartMate or HVAD, it was just easier, not perfect, but easier to take care of these patients when they were discharged, and the families, they had an easier time, and we don't have anything like that other than HeartMate 3. So I think that's what we're left with.
Yeah, I mean, I agree. Because I know I have worked on the Berlin Heart Trial and like years ago when it first started the trial. And I know that it had the issues with the neuro complications.
Yeah.
And those patients, like you said, do have to stay in the hospital for a while until they're hopefully transplanted.
Correct. Yeah, but the hope of these were, there were more, and sometimes just because of the configurations of the pump, not every patient is a HeartMate 3 candidate just based on their size. For adults, it may be. It may be the case, but for pediatrics, no. And so for some select patients, HVAD was a good option, which is not going to be there anymore. So that's a shame. But I think, we'll just have to work around this.
Right. I thought it was interesting. You had mentioned, I believe it was when you were discussing about Berlin Heart, the bivalve Rudin. I believe you had mentioned that what did you, that protocol?
Yeah, so I mean, this is another learning network. I don't know how many people on the call are familiar with it. It's called Action, which is basically, it's a learning network involving different cardiologists and surgeons across the country. And the whole purpose of this was to share protocols and guidelines of how different institutions practice with patients on mechanical support. And out of that, one of the things that they looked at was harmonizing anticoagulation strategies for bad patients. And as a primary aim of that was to use a bivalve as a replacement to heparin, and just standardize bivalve dosing for patients with VADs. And the study that I showed you that's all they did. By protocolizing it, standardizing the dosages, and then looking at patients who were using part of Action and were using that protocol and were on Berlin. And just by doing so, they saw a significant reduction in neurological events and thrombosis rates in general. And so, there's still a few centers who are, controversial about using bivalves and use heparin, but we have switched almost exclusively to bivalve, even in our ECMO patients. And it's definitely easier to manage them for sure.
Great. Thank you so much. I actually had one more question. I don't see anyone from the audience asking, but I had a question, and Patricia, you may see this as well in PDMAX. Frequently we see, for instance, the scenario is like the patient will have like, a different type of cannulas. I want to say like a Rotaflow, and they're connected to another device brand. Is that common in the because I don't really see that in the adult population.
In the adults, I think it's also different because temporary VADs are not used that often. And if someone and the most common strategy that they are used in for adults is if they have difficulty weaning off bypass. And in those instances, it's almost always easier to just keep them or switch them on ECMO rather than employing a VAD strategy. Having said that, if they were to use a temporary strategy, it's usually, the reason why it's different is it just depends on what pumps you have available, the actual pumps. I mean, the circuit is going to involve some tubing and some cannulas that can be either or, but it all comes down to what pump the hospital carries. And you can basically hook one to the other, or vice versa, make it work.
Okay, thanks for explaining that. Well, again, thank you for your time today. I'm just going to go. We're about the end of our webinar today. And so I'm just going to go over some contact information for the sites. But thank you again, Dr. Ashfaq, for your time and your expertise. It was very informative, and thank you.
You're welcome. Thank you very much for having me.